Bom dia a todos, sejam bem-vindos a mais um dia de Breastmit. É a quinta edição do Breastmit. Antes de mais nada, gostaria de agradecer à Sociedade Brasileira de Mastologia Nacional, Sociedade Brasileira de Mastologia Minas Gerais, nas pessoas do Dr. Tufi, presidente nacional, e doutora Bárbara, presidente de Minas Gerais, e aos nossos apoiadores, a BD, a GRB, a Cicobi Credicom, a Siemens, a Roche e a AstraZeneca. Vamos seguir com o Congresso de Tratamento Mínimo e Imagem da Mama, discutindo temas importantes do descalonamento. Para a próxima mesa, que é a mesa sobre personalizando a terapia de acordo com a resposta à quimioterapia neoadjuvante, eu convido a doutora Renata Capanema Saliba Franco, tesoureira da Sociedade Brasileira de Mastologia de Minas Gerais, médica, mastologista do Hospital Mater Dei e da Fundação Hospital da Baleia.
Bom dia, senhoras e senhores. Então, vamos dar início ao nosso bloco 12 do Breastmit, personalizando a terapia de acordo com a resposta à quimioterapia neoadjuvante. Então, agora eu vou apresentar o mini currículo dos nossos 5 próximos palestrantes e fazer a introdução das aulas. Vamos começar com o Dr. Ritse Mann, que é radiologista da mama no Radboud University Medical Center e Dutch Cancer Institute em Amsterdã, na Holanda. Lidera o grupo de trabalho em diagnósticos do Dutch Breast Cancer Research Group e é presidente do Comitê Científico da Sociedade Europeia de Imagem da Mama, que vai ministrar a aula Personalização da Terapia Sistêmica Neoadjuvante, guiada por imagem, o Estudo TRAIN. Depois, com a palestra Omissão Seletiva de Radioterapia Adjuvante após terapia sistêmica neoadjuvante resposta patológica completa, o estudo Descartes, pela doutora Frederieke van Duijnhoven, que é secretária do Grupo de Câncer de Mama do IORTC e co-investigadora dos estudos MICRA e do LORD. A seguir, Dr. Toraf Reimer, que é vice-diretor do Departamento de Ginecologia e Obstetrícia da Universidade de Rostock, na Alemanha, vai apresentar a omissão da biópsia do linfonodo sentinela após terapia sistêmica neoadjuvante, a perspectiva do EUBreast-01. A nossa quarta aula, pelo Dr. Han Boyle, que é especialista em cirurgia da mama e cirurgião com plástica, painéis multigênicos, genômica espacial e transcriptômica, que vai apresentar a omissão da cirurgia de mama, The Optimist, e cirurgia axilar, The Asvan, após terapia sistêmica neoadjuvante. E, por fim, nossa última apresentação pela doutora Maya Rausch, que é médica, professora e vice-presidente de pesquisa do Departamento de Imagem do Abdômen e diretora do Laboratório de Imagem Funcional da Universidade do Texas, MD Anderson. Atualização sobre a eliminação da cirurgia para câncer de mama em pacientes com resposta excepcional após terapia sistêmica neoadjuvante. Ensaio clínico do UT MD Anderson Cancer Center. Considerações em imagem.
Hi, my name is Ritse Mann, and I would like to talk in this talk to you about a new concept in treatment de-escalation that actually focuses on image-guided adaptation of systemic therapy. Right, we have been adapting surgery quite a bit with imaging. So far, systemic therapy has been a little bit out of reach, but it is slowly changing. I have to say that I've worked with a number of companies. Please have a look. And now we are going to talk. If you talk about systemic breast cancer treatment, then there's a number of times in therapy when that actually occurs. Right, after detection of cancer, there is the period before surgery, which is usually called neoadjuvant or primary systemic therapy. Then after surgery, we have the adjuvant phase, and eventually after the detection of metastasis, we have the palliative phase. In all of these different steps, patients get a lot of systemic therapy. In the palliative phase, we do a lot of follow-up. Right, basically what we tend to do there is things like this, where a case goes from this to that, and then we basically acknowledge that we do not have the capacity to actually treat this cancer currently well. It is likely escaping the current treatment that the patient is getting. This is obviously a palliative case. but you would like to keep it at bay, more or less, right? And here the goal is to basically find the moment to intervene when the cancer is not yet exploded, but is actually progressing, so you can shift one systemic therapy to another to still catch the part of the cancer that evades the treatment. Here, just another example where we basically failed, right? The cancer here has been progressed to this, and the patient subsequently got liver failure. The obvious trick is to find it just before it does that. So we can actually shift one sort of systemic therapy in the palliative phase to another to extend life and actually quality of life as good and as long as possible. One of the things you can do with imaging is search for metastasis. We are not doing that a lot yet, but theoretically, if you find oligometastatic disease, you can still curatively treat patients if you actually provide focal therapy to the metastasis that is detected, provided that is obviously the only one. What you see is there is not that much gain in terms of survival, except potentially from patients with HER2 positive and triple negative breast cancers, where it actually does seem viable. The other thing is also that you would be capable of looking for oligoprogression. That means that we have cases like we were just looking at, where on the CT you see that most of the metastasis remain stable. However, there's one or two that basically escaped treatment. They are somehow growing. There's likely a new mutation in these cancers. And rather than just shifting the systemic therapy for all the metastasis in there, you could basically shift or treat these escaping metastasis locally and subsequently continue with the type of systemic therapy that you are using, because actually the other metastases are responding well on it. That's basically what we call oligoprogression. Now, in this talk, I would like to talk a little bit about the neoadjuvant phase, where there is a cancer, and we tend to look at that mostly with MR. And then we'll see that the cancer becomes smaller and hopefully it disappears. So we tell, and most of the time we give patients a good feeling there because the cancer is really responding to the systemic therapy. But we do hardly impact the systemic therapy, but that is still possible, right? This is a very practical example, a place where imaging actually has a big role. This is actually also a palliative case. Look at the date of birth, 1933. Right, and she was detected with a cancer of roughly 11 millimeters, palpable, obviously, because she's beyond the age for screening, and she was put on, obviously, endocrine treatment, right? And we use imaging here to make sure that the cancer is not suddenly massively growing. You see that from 1 year to the next. It is actually getting a little bit bigger. It is not completely controlled with the endocrine therapy, but the likelihood for this patient that she dies of something else than this breast cancer is almost 100%. So why would we bother, right? And while there's obviously also a potential candidate for cryoablation if she would not take the endocrine therapy very well, imaging can here play an important role in just making sure that the breast cancer is not going to give a lot of problems. What you see is that endocrine therapy in monotherapy in elderly patients might prevent basically over the course of 5 years, 75% of the interventions, right? Obviously, there are cancers that are escaping the endocrine therapy that you still need to intervene in, but actually 3/4 of cancers are not. And for those, you could basically say, okay, and we follow you with imaging, and please don't bother with that, reducing the impact of either systemic therapy or in this case surgery. We obviously know that imaging characteristics at baseline are sort of predictive of outcome. So round masses and well-circumscribed tumors are far much likely to respond very well to systemic chemotherapy and may disappear as snow for the sun. Now, we do quite often these early response evaluations after 3 to 4 different courses of a specific type of chemotherapy, but very often then the treatment is anyway shifted, so you do not really impact regardless of what you see on the response evaluation. If you look at PET-CT, likewise, predictive of response, high standardized uptake values basically lead to a very good response, which is a bit counterintuitive, but same as the cancers on MR, right? If they look aggressive, they are likely best responding to this chemotherapy. The downside of it is obviously there's still the patients that die from the cancer. Anyway, you see here that there's a massive decrease in the standardized uptake value, and as a consequence, there is a very good and early response of this cancer in this patient. I'd like to talk to you about a study that actually used PET-CT a little bit more specific to tailor treatment. It's called Fergain. It was run in the States, if I'm not mistaken. And Fergain basically did exactly this. They made a PET-CT in the beginning, and then they actually gave these patients one of two treatments. TCHP is standard chemo plus targeted therapy against HER2-positive cancers, because all these cancers are HER2-positive. And then in group B, there's only HMP, which is trastuzumab and pertuzumab, right? Only anti-HER2 therapy. They got 2 cycles of that, and then they did a PET scan again, right? And looked at decrease in the standardized uptake value here. And if that was really well, right, they would continue on this this targeted therapy only, right? 40% decrease in standardized uptake value would propel them to a chemotherapy, or not, a systemic therapy regimen without chemotherapy, whereas otherwise they would still get into the TCHP stuff, which includes the chemotherapy itself. Obviously, then they went on to surgery, and a group of these patients eventually achieved a PCR and would never ever get chemotherapy, whereas the non-PCR group would still get the chemotherapy in the adjuvant setting, right? And what you see is that roughly 38% of the responders in group B achieved a PCR, which means that there's roughly 40% of the patients that can actually be treated with only anti-HER2 therapy, but no chemotherapy. The total percentage of PCR in that group is, however, a bit lower than in the other group, right? So there are definitely patients there that benefit from the addition of chemotherapy that are sort of missed in this population. However, here you should realize that they get the chemotherapy afterwards. If you look in the PET-CT group, then in group B, it's a little bit less easy to predict the response than in group A, which is a bit nasty, because here we would like to do that, right? FDG PET as such provides a good indication that it's possible, but not a fantastic indication. In practice, we do not actually use PET-CT for evaluating the primary tumor in the breast. Rather, we tend to use MRI, right? And this is what you would like to see. You have a very nicely shaped mass, and it just disappears. You might keep a scar there, but there's no uptake of contrast. And as a consequence, this is actually a radiological complete response, also eventually a pathological complete response. For that, I would like to talk about a trial that was published earlier this year. It's called TRAIN-3, in which patients were treated with a combination of chemotherapy and anti-HER2 therapy. And they got, it's called PTCP here, which is sort of the same as the TCHP in the previous slide. So it contains pertuzumab and trastuzumab and some specific chemotherapies, and patients in our hospital actually get 9 cycles of that, right, normally. And what we did after 3 cycles, after 6 cycles, and at the end, is look whether there was a radiological complete response. And if there was a radiological complete response, the chemotherapy was stopped and the patient was propelled to surgery. So again, only HER2-positive breast cancer. That is because we have a remarkable response rate with systemic therapy in HER2-positive breast cancers, right? The minute we get similar response rates in other types of cancer, and currently we are already at that level in triple negatives, you get similar trials in other types of breast cancer. Then every 3 cycles MRI surgery when a radiological complete response is achieved. And if there's also a pathological complete response, they will never get the chemo, or they will not get the additional courses. That's more or less the idea. MR follow-up in TRAIN 3 looked like this. So there is a tumor here. After 3 cycles, it looked like that. After 6 cycles, it's gone. So after 6 cycles, this patient is actually operated on. What you see in the response rates is that actually in patients with HER2 positive ER negative disease, if we say there is a radiological complete response, there's also a very good likelihood that there is a pathological complete response, right? It's always roughly 88 to 90%. And as such, it doesn't matter when you say it. If you say it, there's 90% likelihood that there's also really a pathological complete response. Obviously, for some of these patients, they could have continued a bit longer, but they will get the cycles at the end, right? And we could prevent potentially giving a lot of chemotherapy here. What you see is that our prediction in patients with ER positive disease is not as good. About 50% of the patients where we say there's a radiological complete response also has a pathological complete response. Nonetheless, that's also quite stable. After 3 cycles, it's just as good as after 6 cycles or after 9 cycles. Just that in ER positive disease, our negative predictive value of MR is not as good as we wished it would be. What is important here is that if you look at toxicity of the chemotherapy after 1 to 3 cycles, 4 to 6 cycles, and 7 to 9 cycles, it really increases the more you get, right? In essence, any serious toxicity is present in about 43% of patients after 1 to 3 cycles, in 74% of patients after 4 to 6 cycles, and in 81% after 7 to 9 cycles. So you would spare roughly half of the serious side effects if you could just stop there. Back to Vergen, that also did something like that, and they actually went a step further, and they looked also at 3-year ipsilateral disease-free survival and overall survival. And what you see also in Vergen is that basically the amount of side effects, serious side effects, halved, right? From 62 to 33%, from 28 to 14%. The disease-free survival is a little bit lower, but not really much, and the overall survival isn't changed. So with that in the back of your mind, there is definitely a group of patients that could benefit from only anti-HER2 targeted therapy, and they can be selected by imaging. In this case, PET-CT, but as you saw in TRAIN, you could also use this for, or you could also do this with MR. Obviously, you would like to see the 3 years results of TRAIN as well. You will get those if you actually visit San Antonio Breast Cancer Conference, because they will be presented there in 2024, sorry. What you should realize is there are currently also similar trials underway, for example, for patients with triple negative breast cancer, right? That are, for example, here treated with a combination of doxorubicin and cyclophosphamide, and additional therapies are only added in case there is not a lot of decrease in tumor volume, right? And otherwise you stay on a relatively limited scheme. So there's a lot going on to figure out whether we can use imaging, in this case even ultrasound, to actually adapt chemotherapy therapeutic regimen. So we are at the end of this. In conclusion, imaging is really predictive of response. That is well known and for a long time. There are actually several image-guided systemic treatment modification trials underway. Some actually already have published very interesting results. And I think imaging can be used to both intensify and de-escalate systemic therapy. And I think that's really a new thing. Successful implementation of imaging in these kind of therapeutic trials may reduce toxicity, may increase survival, and may reduce the overall cost. That's it. Thanks for your attention. Please let me know if you have any questions.
Hi, everyone. Thank you for inviting me. My name is Frederieke van Duijnhoven. I'm a surgical oncologist at the Netherlands Cancer Institute in Amsterdam, and I would like to tell you a little bit about our clinical trial, the DECART study. I don't have any disclosures. So what breast surgery used to be like, or actually breast cancer treatment, we would start with surgery, then radiation therapy, and afterwards, in most cases, chemotherapy. Of course, things have changed, and now we often start with chemotherapy, then followed by surgery, and then radiation therapy. And what we find is that in a large number of patients, there is no residual cancer when we do surgery, so there's a pathologic complete response. Which of course begs the question, what the additional value would be of surgery in these patients, if not of radiation therapy. We know from previous studies that if there's a PCR present, so pathologic complete response, the 5-year local regional recurrence rate is quite low. Reported rates are between 0 and 5.7%, as seen in the slide here. A recent systematic literature review of 66 studies indicated that the presence of PCR is one of the most important factors when predicting prognosis in patients treated with neoadjuvant chemotherapy with an odds ratio of 0.36. And when we look at the relation between PCR and survival, there were 2 studies published in the past few years. One was a National Cancer Database retrospective analysis in node-positive patients, showing that if there's PCR of the nodal component, the hazard ratio for overall survival is 0.57. And then the German breast group trials were retrospectively analyzed for the PCR patients, which were over 2,000 patients. And what was shown that in this patient group, so patients with a pathologic complete response, the prognosis was influenced by the presence of nodal disease before start of neoadjuvant treatment, by the subtype with triple negative and HER2 positive disease being associated with worse overall survival, and specifically for HER2 positive patients, tumor size. This was also confirmed by a study in GCO in 2023, in which patients with HER2 positive disease were included, over 1,400 PCR patients, showing that nodal status and tumor size remain important prognostic factors even if PCR is present. So what happens if we omit radiation therapy in patients with a PCR? There are some data. This study by Mandish showed that in 364 patients who were who included all tumor stages, including nodal disease up to N3, all ages, all sizes, all subtypes, that in those patients with the PCR, the addition of radiation therapy following breast conserving surgery that was not associated with a worse overall survival. So promising results from retrospective data. Similarly, we know from a Japanese study that radiation can be omitted in patients with PCR following breast conserving surgery without a very big effect on the local recurrence rate, showing that 5-year local recurrence of patients for all subtypes was only 1.8% without radiation therapy versus 1.1% if radiation was performed. So why would you consider omitting radiation therapy rather than omitting surgery? Well, I personally think that when you do surgery, it's a small procedure. You have to remove only a very small area of the breast. There is some short-term morbidity, of course, but well, if there's a recurrence, you can do repeat breast conserving surgery, technically speaking. Whereas if you apply radiation therapy, the patient has to undergo 1 to up to 3 weeks of daily courses of radiation therapy, and 1 in 4 patients will report fibrosis and pain, and these side effects are related to the radiation dose. Of course, this has a detrimental effect on quality of life, and if there's a recurrence and you've already done the radiation therapy, in most cases, the patient has to undergo salvage mastectomy. In addition, very important for the medical oncologist is that the reliable assessment of the presence or absence of a PCR is essential to guide adjuvant treatment, mainly for triple negative and HER2 positive patients. So time, of course, to assess this in a prospective fashion, which we are doing in the Descartes trial. It's a prospective single-arm multi-center national trial, and the intervention, it's a simple study. We omit radiation therapy. Almost 600 patients are to be included, and we expect a 5-year local recurrence risk of about 4%. Of course, other factors will be assessed, such as quality of life and metastatic disease and survival. Patients can be included with tumors less than 5 centimeters and no nodal disease at presentation. They have to undergo breast conserving surgery and sentinel node biopsy, and there has to be a pathologic complete response. So also no residual DCIS is allowed. All subtypes may be included, but there has to be a unifocal disease. So this is the study flow here on the left side here. breast cancer patients, PCR after breast conserving surgery. We assess baseline patient characteristics and quality of life questionnaires, omitting radiation therapy, and then follow up for 5 years with annual mammography or MRI and quality of life questionnaires at year 1 and 4. So the study is going quite well. Accrual is ahead of schedule with 320 out of 595 patients included, and all centers that are including are now open for inclusion. Of course, we're not the only one to do such a trial. There are similar trials ongoing, which will hopefully reinforce all the results. There's a Canada trial, the Rosalie trial by the Ontario Clinical Oncology Group, which is a prospective single-arm multi-center trial as well. They do include larger tumors, but other than that, it's pretty much the same set of patients and similar number of patients to be included. Accrual has started and they are still initiating participating centers. Then the US HERO trial is a multi-center prospective trial, which includes only HER2-positive patients, both treated with primary surgery and following neoadjuvant systemic therapy. So not yet sure how many PCR patients will be included, and they have to be over 40 years old, so a slightly different, more narrow patient group. The study has opened last year, and 13 patients have now been included. So still quite a way to go. This is, of course, not the only option to de-escalate following neoadjuvant systemic therapy. You could also consider omitting the sentinel node. There are some trials that assess this, a German and a Dutch trial, both single arm. You do an MRI, and if there's a complete response after neoadjuvant therapy, you do not do a sentinel node biopsy. However, the question is, if you also want to omit radiation therapy, would you feel reassured without confirmation of the nodal status following neoadjuvant therapy? So this seems to be a competing de-escalation option. Of course, as I showed on one of the previous slides, there's also the option to omit surgery rather than the radiation therapy. This has been assessed in a small study in MD Anderson by my colleague Henry Cure. Patients over 40 years old were included with TN1, 2, and 01 triple negative or HER2 positive breast cancer. They had neoadjuvant therapy, and if there was a residual lesion of less than 2 centimeters, biopsies were performed. If they show PCR, surgery was omitted, and then the radiation was, of course, given, including a boost. So quite an intensive schedule. 31 patients were assessed, and at 26 months, there were no local recurrences reported, and the quality of life outcomes have also been reported at 36 months. And not surprisingly, there is some decrease over time of the cosmetic subscore, since the radiation therapy effects will, of course, have their effect over time and not at short term. So also a very interesting option. So I guess that in the future, there will be several options that we may discuss with the patients. First of all, I do think there will be improvement in the way that we assess the response following neoadjuvant therapy by MRI, possibly PET, maybe other modalities will emerge so that we can more reliably assess the presence or absence of a PCR and act accordingly. And then afterwards, of course, we have to discuss with the patients what she thinks is for her situation best suited. Would you rather omit the breast surgery, the sentinel node biopsy, the radiation, and you have to weigh the pros and cons. Because we all know what happens if you do less of the one thing, you mostly end up doing more of the other thing. And that's, I think, one of the things that we have to be very wary of, that we do not replace one option with another one. So I think an exciting future with, in the end, benefit for patient and doctors alike. And I think this was well within the allotted time, and I thank you for your attention.
Hello from my side, and thank you to the organizing committee to invite me to give the talk about omission of sentinel lymph node biopsy in the neoadjuvant setting and to discuss the UBreast-1 perspective. My name is Toraf Reimer from the University of Rostock, and I'm the Deputy Director of the Breast Center at our university, and I'm the Principal Investigator together with Oreste Gentilini from Milan, Italy, for the UBreast-1 trial. These are my COIs related to the UBreast-1 trial, which is a surgical trial. Sponsorship for UBreast-1 was overtaken by the University Medicine of Rostock. As mentioned before, Professor Oreste Gentilini, well known as principal investigator from the SOUND trial, is my co-chair in this trial. Eduardo Botterdi from Milan, Italy, is responsible for the statistical part, and the German Breast Group, located in Neu-Isenburg, Germany, is responsible for data management and monitoring. Background for the trial is the standard approach for triple negative and HER2-positive breast cancer patient is the neoadjuvant systemic therapy. Highest rates of breast and highest rates of nodal pathological complete response, nodal PCR and breast PCR, were seen in these two tumor subtypes, and we designed together with the UBreast network, together with Oreste Gentilini, an uncontrolled single-arm study comparable to the adjuvant well-known APT trial. This single-arm trial was able to report significant results with practice-changing potential. Using a single-arm design, we will get hopefully reliable results in a shorter period of time, saving resources which are needed to conduct a randomized trial. What is the current standard? What say the guidelines for node-negative patients in the neoadjuvant setting? Of course, standard procedure is the axillary sentinel lymph node biopsy here, highest degree of recommendation, double plus, and then after receiving final pathological result in case of micrometastasis or in case of macrometastasis, you have to discuss or you have to do a completion axillary lymph node dissection. And here you can see the link to our trial using an asterisk. Study participation in the UBreast-1 trial is recommended using this German guideline slide. One sentence to the current standard approach, sentinel lymph node biopsy in the neoadjuvant setting. In the false negative rate for the sentinel in the neoadjuvant setting is a little bit higher when you do in comparison to the primary adjuvant setting. In the neoadjuvant setting, the false negative rate is reported between 6 and 12% in this publication by Monica Morrow in 2020. This is the first paper published in the European Journal of Cancer 2012 by Husami, investigating the PCR rates with respect to intrinsic tumor subtypes with high patient numbers, and you can see very well HER2-positive triple negative cohorts are showing the highest rates of PCR, not only in the breast, but only in the breast and in the axilla. And if you compare these rates to the hormone receptor positive HER2 negative subtypes, the PCR rates for these subtypes are much lower compared to HER2 positive and triple negative cohorts. This is a publication of a Dutch group published in 2021, doing a pooled analysis of node negative patients in the neoadjuvant setting regarding axillary PCR rates with respect to the tumor subtypes. And again, in this study, triple negative and HER2 positive cohorts showed the highest rates of PCR rates in the axilla, nearly 50% for the triple negative cohort, nearly 60% for the HER2 positive cohort, with a more up-to-date treatment regimens if you compare this with the publication by Hosami in 2012. UBreast-1 is a prospective, multi-center, single-arm international trial. And candidates for UBreast-1 recruitment are patients initially node negative in the neoadjuvant setting, patients with triple negative HER2 positive breast carcinoma, and finally patients with a radiological complete response after completion of neoadjuvant systemic therapy. This is the flowchart. This is the design of the UBreast-1 trial according to the last amendment, number 3. And you can see here the inclusion criteria, and in red you can see the target patient numbers for the screening cohort and for the per protocol cohort. Recruitment is open for T1, 2, 3, 3 breast carcinomas, initially node negative, triple negative, HER2 positive, invasive breast carcinoma. Then, after complete radiological response, after the end of neoadjuvant systemic therapy, the patient is ready for registration in this trial. Please remember, there's no randomization, there's only a registration in this trial, and then the patient will undergo breast conserving surgery without any axillary intervention. And if you have the case of breast PCR, that means no invasive residual disease after final pathology report. The patients will go into the per protocol cohort, and we are doing the further follow-up for the primary outcome, which is the 3-year axillary recurrence-free survival of these patients. We expect a PCR rate in the breast of nearly 80%. That means nearly 20% of these patients will go out from the trial because they have a non-PCR on the breast. These patients will receive the sentinel lymph node biopsy as standard procedure outside from the trial, and then further treatment is depending on the final pathology result of the sentinel lymph node biopsy. The UBreast-1 trial is not the only trial investigating the omission of sentinel lymph node biopsy in the neoadjuvant setting. There is a large trial, the ASLAN trial from South Korea. I think you will hear information and insights about this trial from South Korea. About this trial from South Korea in another presentation during this meeting by my colleague from South Korea. I think the ASLAN trial is fully recruited now, and there is a third trial running as monocentric trial in the Netherlands, the ESSEX trials, but this trial will probably have a recruitment number below 100 because the monocentric design. The background for all of these trials are the data from cancer registry analysis. Here you can see different papers investigating node negative patients in the neoadjuvant setting. All patients underwent breast and axillary surgery, and if you look to the node positivity, a node positive rate after completion of neoadjuvant systemic therapy, again for the HER2 positive and for the triple negative cohorts, the rates were here in this paper between 0 and 1.6%, very, very low in initially node negative patients. The number are highest for the hormone receptor positive, HER2 negative cohort. Primary outcome of the UBreast-1 trial is the 3-year auxiliary recurrence-free survival. Secondary outcomes are listed here. Of course, also the auxiliary recurrence rates. And finally, we are evaluating the diagnostic accuracy of imaging methods for prediction of PCR rates in the breast after neoadjuvant systemic therapy. For sample size calculation, we have defined upper and lower margins for the primary outcome. The trial will be positive if we observe a rate of 98.5% for the 3-year auxiliary recurrence-free survival. And the trial will be stayed as negative if we observe a rate of less than 96% for the primary outcome parameter. Using these margins, finally, we need approximately 350 patients for the per protocol analysis. Now some insights from the first 300 patients recruited into the uBreast-1 trial. Here you can see the distribution between tumor stage, 50% T1 tumor, 50% T2 tumors. Of course, all patients with node negative status at the time point of diagnosis, no detection of distant metastasis. And here you can see the distribution of the intrinsic subtypes. A little bit more than 60% are triple negative, and nearly 40% have HER2 positive characteristics. No surprises when you are looking to the neoadjuvant systemic treatment regimens for the neoadjuvant chemotherapy. The combination of taxane and anthracyclines was seen in the majority of patients, and for the anti-HER2 therapy, the combination of trastuzumab and pertuzumab was documented for the great majority of uBreast-1 patients. I think this slide is quite of interest because here we are analyzing the breast PCR rate in the screening cohort of uBreast-1 patients, and you can see in real world at the moment we have breast PCR rate of 78%. This is nearly to the expected 80%. So probably we do not have to change the target patient number, including 350 patients for the per protocol analysis. If you want to have further information, here is a review paper published in December 2020 in the journal Cancers with all available data leading to the final uBreast-1 protocol. This full paper has free access, and very recently I published a review regarding omission of axillary sentinel lymph node biopsy in early breast cancer patients, and the second part of this review is discussing the available data and the trial projects in the neoadjuvant setting. Again, this full paper is of free access in the Medline database. These are the timelines for the uBreast-1 trial. First patient in was in January 2021. Last patient in, we expect the recruitment of the last patient in December 2024. So hopefully we can do the primary outcome and the secondary outcome analysis in January 2028. We have 50 study sites open for recruitment at the moment. The great majority is located in Germany, but as mentioned before, this is an international trial, and also study sites from Italy, Austria, and Spain are supporting this project. Finally, these are the contact addresses if you want have further information located at the University of Rostock or at the German Breast Group in Neu-Isenburg, Germany. And finally, I want to say thank you for your attention for this presentation, and I want to say thank you for supporting the UBreast network, which is not only focused on European corporations, and at the moment we have projects worldwide, and I think also study sites in Brazil are supporting different UBreast projects, doing recruitment of patients for these trials. Thank you very much.
Hello, everyone. This is Hanbyo Lee at Seoul National University Hospital. I'm currently a visiting scholar at UC Irvine. It is an honor for me to speak here today at Breastmit on the admission of surgery trials conducted in South Korea, the Optimus and the Aslan trial for patients after neoadjuvant systemic treatment. This is my disclosure slide. I always like to share this slide presented by Dr. Osborne at the ASCO meeting in 2016. It well summarizes the evolution of breast cancer treatment, where it evolved into less surgical therapy and then to more systemic therapy, then into less chemotherapy and a more targeted therapy approach with all the molecular characterization and targeted therapy drugs developed. Now we're in an era where we're providing even less surgical therapy, and we call this de-escalation. Actually, I don't like this word very much because we do escalate sometimes, and I like to call it optimization of treatment. When we look at the journey map of breast cancer patients, about 70% of the patients receive upfront surgery, about 30 to 35% receive neoadjuvant systemic treatment. And there are I would like to highlight some of the trials that avoid treatment or surgery. These trials sound in SEMA, Nautilus, and Boob. 1308 tries to avoid sentinel lymph node biopsy. We now have trials looking at active surveillance for low-grade and intermediate-grade DCIS. And for patients receiving neoadjuvant systemic therapy, I'm sure you heard of the talk previously about the CAR-Ts trying to avoid radiation therapy in patients with pathologic CR. And today I would like to talk about the Aslan trial, which tries to avoid sentinel lymph node biopsy, and also the Optimus trial that tries to omit surgery for the breast after neoadjuvant systemic therapy. This is a situation we encounter every day in the clinic after neoadjuvant chemotherapy, neoadjuvant systemic therapy, on imaging tests and physical examination. When it suggests that the tumor may be all gone, or a radiologic or clinical CR, and the patient always asks, "Do we need surgery then, or can we not forgo surgery?" However, the golden standard as of now is to perform surgery. And the purpose of that is to confirm that she has a pathologic complete response. We now know that patients with a PCR after neoadjuvant systemic therapy has a very favorable long-term outcome, especially for HER2-positive, triple-negative, and high-grade luminal type cancers. And another study shows that about 86% to 90% event-free survival for triple-negative and HER2-positive cancers who achieve a PCR after neoadjuvant chemotherapy. We can expect in a range of 60 to 70% PCR rate for HER2-positive cancers, and about even exceeding 30 to 40% for triple-negative breast cancers now. But for patients who does not achieve a PCR, we do have options of adjuvant chemotherapy and targeted therapy. When we look at the role of breast surgery after neoadjuvant systemic therapy, if there is residual tumor, of course, the surgical removal of the tumor is its role. However, in this case, we can expect poor outcomes even with the additional therapy. However, with patients with the pathologic CR, the role of surgery is really for the pathologic confirmation. What if the patient has a pathologic CR in the breast? Does that translate to pathologic CR in the lymph nodes also? When we look at the residual external lymph node metastasis in patients with a PCR, it is in the range of between 1 to 3% for patients with a clinical N0 disease before neoadjuvant systemic therapy. However, for N1 disease, it exceeds 10%, and in some trials it was nearly over 50%. So we do have these trials now. I'm sure Dr. Reimer talked about the EU Breast 01 trial in detail, so I won't go into detail about these trials. However, these 3 trials all go through breast surgery first to confirm that there is no residual tumor, and if PCR is confirmed, they forgo sentinel lymph node biopsy. So in contrast to the EU Breast 01 trial, ASLAN trial includes clinical N1 tumors as well. And also, we look at the recurrence-free survival. We thought that compared to the local regional recurrences, the impact that the sentinel lymph node biopsy or the X-ray staging operation has on the recurrence-free survival may be more important. Another reason for this is that in Korea, we performed a survey looking at the disparities in clinical end staging. So we were able to find out that only 62% performed external lymph node biopsy before neoadjuvant systemic therapy. 42% used the number of sites of suspicious lymph nodes on imaging to do the clinical staging. And also 77% responded that reimbursement regulations in Korea affected the selection of the staging, nodal staging in practice. So this is the summary of the ASLAN trial. We enroll patients with HER2 positive or TNBC, and we did include patients with low ER patients as well, And we look at the radiology response after neoadjuvant systemic therapy. We include patients with a mass 2 centimeters or smaller, or a non-mass enhancement of 4 centimeters or smaller on MRI. And we enrolled 178 patients with a PCR in the breast confirmed after surgery. And this was led by Dr. Jung-Eun Lee at Samsung Medical Center. And we enrolled patients from 5 tertiary hospitals in Korea. Now we have completed the accrual of 182 patients. There were some patients coincidentally enrolled near the end of the period. So the data has been locked, and we're going to be we finished the accrual, and we'll be looking at the 5-year event-free survival up until 2028. Fortunately, the first report of the clinical pathologic characteristics of the ASLAN trial has been selected for poster spotlight presentation this year at San Antonio Breast Cancer Symposium. I will be presenting on Thursday, sharing with you these kind of information on the distribution of the stages, subtypes, PCR rate, axillary surgery results from non-breast PCR patients, and also the characteristics of those patients as well. So stay tuned for that. So when we go back to this slide, what is the role of breast surgery after neoadjuvant systemic therapy? If it's pathologic confirmation, do we need surgery for that? Are there any other alternatives? In order to show that we can avoid or omit surgery for the breast, ideally a randomized trial for a patient with a PCR to go under omitting surgery or receiving standard breast cancer conserving surgery, followed by radiation therapy. But in order to do that, we need a reliable ways to predict the PCR. So there have been many trials looking into this, where we can to see if we can use minimally invasive biopsy to predict PCR correctly. Several feasibility trial studies by Dr. Jörg Hale, who's also a speaker at Breastmit, and also Dr. Henry Kerr at MD Anderson and our group here at SNUH. Some pooled analyses, and also these prospective phase 2 trials, including the Responder, MITRA, and NRGB-005 trials, which were presented at San Antonio Breast Cancer Symposium in 2019. This was a dinner that we had together with all the investigators in this subject. And learning from these numerous studies, we found out that we improved accuracy of the minimal invasive biopsy in terms of false negative rate and negative predictive value is to use a Clint marker for the tumor, histopathologic evaluation of representativeness for the tumor bed really helps, sufficient number of cores and volume obtained on vacuum-assisted biopsy, strict requirements for imaging findings after neoadjuvant systemic therapy, standardization of the procedures in institutions with breast specialists, and also the exclusion of hormone receptor positive and HER2 negative tumors. They really respond in a scattered pattern so that we cannot really biopsy the lesion correctly. We do have this study conducted at our institution where we show that using an MRI size and something called a lesion to background signal enhancement ratio, and if we get a sufficient number of cores, we can obtain 100% accuracy. And this pooled analysis presented at San Antonio Breast Cancer Symposium 2019 showed that if we use a vacuum-assisted biopsy on a residual tumor, which shows a size of 2 centimeters or smaller on imaging, and if we can get 6 or more representative samples, we can obtain a very good 30.2% false negative rate. And we now have the results from the MD Anderson trial of 50 patients, and 31 of which avoided surgery. I'm sure Dr. Rauch will go into more detail about this trial. And this led to the design of our trial, the Optimus trial in Korea. It's the Korean Breast Cancer Study Group number 24 trial. We started enrolling back in September 2022. If we go into detail, we include HER2 positive or TNBC tumors, and we also include low ER of less than 10% of stage 2 to 3 tumors with a MRI criteria of size 1 centimeter or smaller, or lesion to background signal enhancement ratio of 1.6. We obtain 6 or more cores using a 7 to 10 gauge needle, and we evaluate pathologically for evidence of tumor bed. And this is a very requirement to be enrolled into this trial. So if the tumor has no residual tumor, we omit the surgery for the breast, and we do have the option of omitting sentinel lymph node biopsy also for a more stringent criteria where the size is 5 millimeters or smaller, and the patient had a clinical N0 tumor before neoadjuvant systemic therapy, and also a negative axillary ultrasound after neoadjuvant chemotherapy. Primary endpoint is the 5-year disease-free survival rate compared to the rates in previous studies. We used an assumption of 88% as the 5-year disease-free survival. And with a 4% non-inferiority margin, we need 384 patients with no breast surgery. Using a 10% drop-off rate and a 20% non-PCR rate on vacuum-assisted biopsy, that summed up to 533 patients. Now we're enrolling patients from 17 tertiary centers in Korea. We are at about 24% accrual, We were enrolling on schedule up until February this year. However, I don't know if you've heard of it, but we do have a medical situation, a strike situation in South Korea that led to shortage of doctors and decreased patients in participating tertiary hospitals because we had to send our patients back to the secondary hospitals for treatment. Anyway, this is our current status. We did have the VAB done in 126 patients. And we do have results for 120 patients, of which 105 had a PCR, node residual tumor. And these are the surgeries performed: no surgery, 29 patients, sentinel node biopsy only in 71. There are several ongoing trials also in Japan and in Spain. I'm not going to go into more detail about this, but we do have to look at the actual benefits from elimination of surgery. So we could avoid asymmetry, the scar, complications, general anesthesia, and also the medical expenses. But I think what's most important is how the patients feel about omitting surgery. And I do have good feedback from our patients that they would like to avoid anything they can after going through the hardships of neoadjuvant systemic therapy and chemotherapy. So I really believe that for indolent tumors, less systemic therapy and appropriate local treatment is much better and more important. However, for aggressive tumors, effective systemic therapy and targeted therapy may be more important, and less local treatment can be given for these patients. At Seoul National, we're performing numerous prospective clinical trials. I would like to share with that. And also one more slide about Global Breast Cancer Conference next year at Seoul, Korea. I hope you can check that out. And thank you very much for your attention.
Hello, thank you so much for inviting me to share with you updates on eliminating breast cancer surgery in exceptional responders after neoadjuvant systemic therapy, results of UT MD Anderson Cancer Center clinical trial, and I will be discussing imaging considerations. I have no disclosures. The things that we radiologists always ask ourselves is how imaging can safely select patients for the escalation of breast surgery after neoadjuvant therapy. We have a lot of imaging modalities in our disposal: conventional anatomical imaging, such as mammography and ultrasound. We have functional imaging, and of course, MRI is our power horse. And now we have quantitative imaging, quantitative analysis, deep learning, radiomics, and so on. However, the problem is that none of these imaging modalities at this time have sufficient sensitivity and specificity to predict PCR. However, there is another tool that we imaging radiologists have that can be helpful, and it is stereotactic breast biopsy. Originally, all diagnostic biopsies were surgical, and the stereotactic biopsy was actually developed to select patients who need surgery for malignant disease. Why do not use the same concept for neoadjuvant systemic therapy? At MD Anderson, we actually performed feasibility trial where we tried to identify breast cancer patients who may be eligible for avoidance of surgery, and we published this in a couple of papers, and these are our results. We enrolled 40 TRIP-negative and HER2-positive patients, T1-3 and 0 and 1. We performed a 9-gauge vacuum-assisted core biopsy under stereo or ultrasound guidance, and we also did 2 FNA with 21-gauge needle. Breast PCR was defined as no IDC or DCIS, and it was seen in 47.5% of the patients. And we found that NPV was 90% and accuracy was 95% for these biopsies. We had only 2 false negative in our study. Here is one patient from this cohort, TRIP-negative breast cancer patient who came for treatment of her cancer to MD Anderson, and you can see this circumscribed mass with calcifications. On mammogram and ultrasound, it was palpable. After treatment, it completely dissolved. Just some residual focal asymmetry and calcifications were seen on mammogram. On ultrasound, there was practically nothing. We biopsy it, and we removed residual calcifications. Pathology demonstrated no residual disease. Patient went to surgery and no residual disease was seen there. That was PCR case. Let's review two false negative. This is a patient with triple-negative breast cancer who has this very posterior tumor. You see residual abnormality with marked by clip. This residual focal asymmetry is located right by the chest wall. Therefore, we could not biopsy under stereo guidance. We used ultrasound. It was technically very challenging biopsy. We didn't want to injure chest wall. We took 6 cores and put a second clip, as you can see on the mammogram after procedure. And this was false negative case. Residual disease were seen on surgery. And another one is this patient, and I'm showing ultrasound images here, and you can see that residual mass is right at the skin. It practically involves skin. This is flat tumor bed there. Again, couldn't biopsy under stereo. We used ultrasound. We had to be very careful. We only could take 4 cores because we didn't want to create hole in the skin. So again, it was undersampled, and this was another false negative case that had residual disease at surgery. And therefore, our decision was that for no surgery clinical trials, there are following rules that need to be followed. So we prefer stereotactic guidance. We feel that we need to use large gauge, at least 9 gauge vacuum-assisted core biopsy, and most importantly, number of cores. The lesion needs to be really very well sampled. At least 12 cores need to be updated. All our false negatives were the cases that were undersampled. Very important is careful patient selection and review pre-surgical imaging, like our 2 false negatives. If lesion is too close to the chest wall or it is too close to the skin and it cannot be adequately sampled, these patients are not good candidates for no surgery trials. And it is very important to document adequate sampling, perform post-procedure mammogram, spaceman radiograph. It is good if we can remove clip during biopsy, and then we must put new clip in the biopsy cavity to document sampling, as well as it is important for radiation planning. And now I would like to discuss our multi-center trial on eliminating breast cancer surgery in exceptional responders with neoadjuvant systemic therapy. We have very selective inclusion criteria. As I said, that's really very important. Women age over 40, it has to be unifocal, triple negative, or HER2 positive breast cancer, less than 5 centimeters in size, N0 or N1. Any neoadjuvant systemic therapy can be given, and important, the residual tumor should not be larger than 2 centimeters in size in order for adequate sampling. Exclusion criteria are prior ipsilateral breast cancer, pregnancy, T4, T3 disease, if there is progression of the disease clinically, or if there is distant metastasis development. And this is our schema. You see patient receive neoadjuvant systemic therapy. We biopsy them with stereotactic guidance, at least 12 cores, 9 gauge. Important, lesion size should be less than 2 centimeters after treatment. If there is no residual disease, which means no invasive or in situ disease, patient skips surgery and is followed every 6 months with clinical exam and imaging and primary endpoint, ipsilateral breast tumor recurrence-free survival, and we have a bunch of secondary endpoints. We recently published our preliminary results. We were able to enroll 50 triple-negative and HER2 positive patients. Mean largest tumor size at baseline was 2.3 centimeters. After treatment, it was 0.9 centimeters. 9 gauge stereotactic vacuum-assisted core biopsy. Mean number of samples was 15. As you can see, we realized from our feasibility trial importance of good sampling. So we actually, instead of 12, we had up to 15 samples obtained. These are our PCR results. 31 patients, or 62%, had PCR, 71% in triple-negative breast cancer cases, and 55 HER2-positive patients. And these are our results. None of the patients had ipsilateral breast cancer recurrence at the last analysis. Median follow-up was 42 months. Here is examples from our cohort. Triple-negative breast cancer patient presented with this palpable finding. Biopsied confirmed triple-negative breast cancer, treated with neoadjuvant systemic therapy, and we can see at follow-up at the end of the treatment, there is minimal focal asymmetry. We biopsy this area, remove the clip. You can see the clip in the specimen removed. There was no residual disease in the removed specimen, and this patient has been followed for 3 years without evidence of recurrent disease. One of our secondary endpoints was to determine the incidence of recommendation for biopsy based on breast imaging at follow-up. And the hypothesis was that eliminating breast surgery will make surveillance of the breast imaging easier, and the rate of biopsy should be lower than standard surgery. And our starting point was this paper published in JAMA Surgery, where 121,000 patients Medicare database was reviewed, patients who had breast surgery for breast cancer. And it was found that incidence of breast biopsy was 15% for first 5 years and up to 23% for first 10 years. In our study, 29% of cases had breast biopsy, which is a little bit higher than reported there. But I should mention that 2 cases were contralateral, and if we subtract these cases, it will be around 20%. And all these biopsies were benign and concordant. And again, the threshold for biopsy was really very low because it's a new field, and that also may contributed to high rate of biopsy, relatively high rate of biopsy. Here is one of the patients from our cohort who presented with triple-negative breast cancer. We see mass on baseline mammogram and ultrasound. After treatment, almost nothing seen on ultrasound, residual focal asymmetry on mammogram. Biopsy clip was removed, new clip was placed. No residual disease was seen in the biopsy specimen, so this patient did not have surgery, and we've been following this patient every 6 months. At 12 months follow-up, there was focal asymmetry a little bit denser than before, and you can see on ultrasound, we see this post-biopsy scar with shadowing. Radiologist was concerned and biopsy was performed. You see the second clip placed in the biopsy cavity. Pathology results were benign, and these patients have been followed, and no evidence of recurrent disease. Another secondary endpoint was longitudinal patient-reported outcomes. Patient filled out questionnaires, and results actually were published in JAMA Network in 2023. We measured the following PROs, decision regret scale, which evaluated comfort with decision-making process, breast cancer treatment outcome scale, which evaluated function, cosmesis, pain, edema, and FACT-B+4, which evaluated quality life. It was breast-specific, arm-specific, physical, family, emotional, and functional well-being. And what we found that there was extremely high comfort with their decision to participate in the trial and skip breast surgery. And what most important, over time, decisional comfort increased significantly. There were minimal differences between breast size at baseline, and there was a slight difference between breasts over time, but this is most likely due to radiation therapy because all patients underwent radiation therapy after biopsy. And all patients reported high quality of life at baseline, which further increased over time. Secondary objectives, one of the secondary objectives was to evaluate CTC and ctDNA after neoadjuvant systemic therapy at baseline in patients with PCR after 6 months and after 1 year post-radiotherapy. Results of CTC were calculated from 13 patients over 3 time points, and only 2 patients had positive CTC at baseline. 2 were still positive at 6 months and 1 at 12 months. ctDNA was measured in the 12 patients at 3 time points. 2 patients were positive for TP53 at baseline. 1 was negative and another one was HER2 positive patient. At 6 months, TP53 was negative for 2 negative breast cancer patient, but HER2 positive patients continued to be positive at 6 and 12 months. And there was actually no positive interaction between CTC and ctDNA results identified. But let's ask this question: why skip surgery? What if patient wants to have surgery? However, they don't want radiation therapy, especially if there was no residual disease at surgery. Can we de-escalate radiation therapy? This actually data from NRG B55 showed that nodal PCR, if there is nodal PCR, these patients have no significant benefit in local regional control, disease-free survival, or overall survival with the addition of radiotherapy. So next logical question is, do we need radiation to the breast in someone with a breast PCR? At MD Anderson, we actually have cohort B in our multicentral trial, where patients who have received neoadjuvant systemic therapy, underwent surgery, sentinel lymph node biopsy, there was no residual disease, they skip radiation therapy, and they are followed for every 6 months. And we, again, primary endpoint is the same, epicycloid breast cancer tumor recurrence free survival, and all of these secondary endpoints. In conclusion, it is important to say that field is changing. There are numerous new, better systemic therapies where patients have pathologic complete response, and it is our obligation to study possibility of de-escalation of surgery and radiotherapy. Targeted imaging and biopsy can accurately identify patients without residual disease. And early results of clinical trials on eliminating breast surgery are promising. And our role is to ensure safety and efficacy of these patients with larger clinical trials. Thank you very much for your attention.
Ótimas apresentações. Agora eu vou apresentar os nossos debatedores. Então, temos o mastologista Dr. Clécio Murta, Ênio de Lucena. Ele é mestre e doutor pela UFMG, mastologista do Instituto Horizonte e membro da Academia Mineira de Medicina. Temos o radiologista Dr. Gustavo Machado Badan, que é doutor em medicina pela Faculdade de Ciências Médicas da Santa Casa de São Paulo, coordenador médico da equipe de radiologia mamária do Hospital Santa Catarina Paulista, do Grupo Aliança, e médico da equipe de radiologia mamária do Laboratório A+, Grupo Fleury. Temos a radio-oncologista, doutora Ana Carolina Rezende, que é médica titular do grupo de mama do Centro Oncológico do Hospital Israelita Albert Einstein, tem mestrado em oncologia pelo Hospital Israelita Albert Einstein, residência médica em radioterapia pela Faculdade de Medicina da USP. Também como debatedor, o oncologista Dr. Rodrigo Cunha Guimarães, que é oncologista do Grupo Oncoclínicas e tem mestrado em oncologia pela Universidade de ULM, na Alemanha. E também, para compor a mesa, o mastologista Dr. Vilmar Marques, que é professor adjunto, doutor da Faculdade de Ciências Médicas da Santa Casa de São Paulo, chefe da Clínica de Mastologia da Santa Casa de São Paulo e presidente do Conselho da SBM. Eu queria agradecer aos nossos palestrantes internacionais que estão aqui ao vivo conosco, tá? Vamos aproveitá-los aí para a gente enriquecer essa nossa discussão. Eu queria convidar, né, o Dr. Clécio para começar com as suas considerações.
Obrigado, Renata. Bom dia, senhoras e senhores. Antes de mais nada, cumprimentar e agradecer a organização do Breastmit pelo convite, a honra de poder estar aqui participando, em especial na pessoa do Dr. Henrique Couto. E antes de mais nada, assim, dizer da sensação de vivenciar um momento de mudança tão importante como a gente tem presenciado atualmente na mastologia. E o que a gente teve a oportunidade de assistir aqui nessas brilhantes apresentações, realmente assim, nos mostra um cenário de mudança muito significativo, tanto do ponto de vista do tratamento sistêmico, quanto também do ponto de vista da nossa abordagem cirúrgica e até a questão do papel da radioterapia. A grande questão que a gente fica, e obviamente é uma sensação, particularmente para mim, enquanto cirurgião, é perceber e ter a sensação de segurança suficiente para transmitir aos nossos pacientes que a omissão de qualquer que seja dessa estratégia terapêutica cirúrgica e ou radioterápica, ela é suficiente para a gente assumir isso como uma realidade atual. Mas não tenho dúvida nenhuma de que isso é um cenário, talvez num curto espaço de tempo, que vai fazer parte da nossa prática profissional. A questão toda que a gente fica é a sensação de que esses estudos eles nos mostram, nos sinalizam uma tendência, mas que, a meu ver, nesse momento, ainda me parece uma coisa meio prematura para a gente poder assumir como uma realidade. Mas não tem dúvida nenhuma de que isso aí vai ser um caminho a ser seguido. Todos esses estudos que foram aqui apresentados, mostra para a gente, com algumas limitações, lógico, do ponto de vista metodológico, a gente precisa ressaltar, alguns são estudos de braço único, estudos com um N, alguns até pequeno, e com um tempo de segmento que, para a gente em oncologia, a gente sempre fica um pouco receoso de poder estar afirmando que tipo de condição vai ser o nosso paradigma real no futuro. Vale destacar que, nesse cenário, na resposta pós-tratamento sistêmico, nós dependemos de um estudo radiológico extremamente cuidadoso e eficaz, capaz de nos demonstrar uma resposta absolutamente equivalente ao que a gente constataria na resposta assegurada pela biópsia cirúrgica do material, do espécime obtido. E também a questão que a gente fica, e aí é uma coisa muito pessoal e intrigante, se a gente vai omitir alguns dos tratamentos, omitir a cirurgia, também omitir a radioterapia. Então a gente fica realmente assim, muito receoso de estar assumindo essas duas condutas como uma coisa a ser estabelecida na nossa prática profissional. Mas não tem dúvida que acho que esses dados, esses estudos, eles estão sinalizando para a gente como sendo um cenário viável. O que é fundamental é exatamente a gente definir e pontuar aqueles subgrupos em que realmente isso vai ser uma recomendação. E eu achei assim, muito pertinente a apresentação do professor Lee, quando ele coloca assim, quais as consequências que a gente tem da omissão da cirurgia. Todas as consequências que nós provocamos do ponto de vista da abordagem cirúrgica, os riscos de intercorrências, os riscos das complicações, a deformidade estética, ainda que a gente possa agregar procedimentos corretivos, a oncoplastia e a própria reconstrução, mas para a gente que lida principalmente ou particularmente na questão da área da reconstrução e da oncoplastia, a omissão da radioterapia para nós é uma coisa extremamente interessante, devido às consequências, entre aspas, prejudiciais que a radioterapia acaba provocando como resultado, sobretudo do ponto de vista de resultado estético para essas pacientes. Mas uma coisa que ele comentou que é muito interessante, e aí eu acho que a gente tem um papel fundamental, é a percepção do paciente. E aí, obviamente, entra um viés daquele que vai estar conduzindo ou sendo o maestro da condução do tratamento oncológico dessa paciente, que é você provocar ou induzir uma decisão que aquele indivíduo, que aquele paciente possa tomar dentro da sua crença ou da sua recomendação nessa abordagem terapêutica. Mas, assim, a meu ver, eu acho que está muito claro e a gente está vivenciando um momento de transição grande e que é um futuro muito próximo da gente estar discutindo, sim, para um grupo significativo de pacientes a omissão desses tratamentos tradicionais que a gente usa para o câncer de mama. Então, acho que eram essas minhas considerações. Renata, muito obrigado pela oportunidade.
Queria saber se alguém tem alguma pergunta direta para os nossos convidados internacionais, ou então se o doutor Gustavo... Isso, vamos continuar aí o nosso debate.
Bom dia a todos. Inicialmente gostaria de agradecer ao Henrique pelo convite, né? Uma honra para mim estar aqui hoje com vocês. Cumprimentar todos os debatedores, a você, Renata, apresentadora, moderadora, e parabenizar os palestrantes, né? As palestras foram muito interessantes, a gente ficou entusiasmado com esses avanços da medicina, com os resultados dos trabalhos científicos, e a gente observa que cada vez mais a medicina tem que ser personalizada mesmo, caso a caso, para a gente definir a conduta apropriada para aquela paciente, né? E eu gostaria de saber de todos eles, dos palestrantes, o que eles pensam sobre os exames de imagem, como os exames de imagem podem auxiliar o mastologista, o cirurgião, na decisão terapêutica de realizar primeiro o tratamento sistêmico ao invés de cirurgia upfront, né? Então, por exemplo, é necessário realizar a ultrassonografia de axila para todos os pacientes com diagnóstico de câncer de mama, já que a gente precisa determinar o status axilar para tomar a decisão de realizar a cirurgia upfront ou a quimioterapia neoadjuvante? Qual que é o papel da ressonância magnética de mamas quando a paciente já tem um diagnóstico de câncer de mama? Ela é útil? Ela é desejável? Ela precisa ser realizada para todas as pacientes? Um outro fator que é importante é o tamanho do tumor, né? Quando o tumor tem mais do que 2 centímetros, ele é triplo negativo, ou a gente está diante de um caso HER2 positivo, a paciente inicia o tratamento pela quimioterapia neoadjuvante. Então, será que aqueles tumores que têm uma divergência do tamanho com os exames convencionais, um tumor de 1,5, 1,8 centímetros, a gente deveria realizar uma ressonância magnética para avaliar melhor o tamanho do tumor, para que a gente tivesse uma decisão mais assertiva de qual tratamento a gente deve começar, se é com a cirurgia ou com tratamento sistêmico. Então, eu gostaria de escutar o comentário deles sobre isso.
Dr. Lee? Dr. Frederieke?
Thank you for your comments and question. It is a very important one. For myself, we always do an evaluation of the axilla, the status of the lymph nodes for all our patients before surgery, before treatment decisions. However, especially for high-grade tumors, for instance, triple-negative breast cancer, HER2 positives, it is definitely more advantageous to go on with neoadjuvant systemic therapy in these patients when the tumor is more than 2 centimeters. We don't have enough data for T1C tumors, but for tumors that are more than 2 centimeters, it is definitely advantageous for the patients. So, and we can seek ways to de-escalate surgery or radiation therapy, as we have seen today. In terms of using MRI to assess the tumor size better, I'm not really for that idea. I think traditionally we assess the clinical T staging using basic imaging techniques such as mammogram, ultrasound, and physical exam. An MRI sometimes overestimates the size of the tumor, especially if we see some non-mass enhancement, which in turn is actually usually maybe in situ cancer instead of the invasive tumor that goes into the clinical staging. So I usually order MRI to discover any other lesions or multifocal lesions, but not to assess the tumor size really in the treatment decision process. For luminal cancers, now we do assess the lymph nodes using various modalities, especially with an ultrasound. However, I decide to go for a neoadjuvant systemic therapy for luminal cancers if if there are maybe 3 or 4 or more lymph node enlargements or suspicious lymph nodes. However, if it's less than that, maybe 1 or 2 suspicious lymph nodes, I go for upfront surgery in an effort to use the multigene assays to hope to have the patients avoid chemotherapy in this subtype. So that's my practice.
Dr. Frederieke, could you please give also your opinion about this?
Well, I guess there are always differences on an international level, of course, and as well as guidelines. As my colleague was saying, I think there are quite an advantage of doing neoadjuvant systemic therapy whenever possible. So for the Netherlands, that entails for all triple negative and HER2 positive tumors, we generally start with neoadjuvant systemic therapy. Also because there are some drugs that are only allowed to give in the neoadjuvant setting and not in the adjuvant setting. So if you would do surgery first, then the patient might miss out on specific targeted therapy for HER2 as well as for triple negative. And in addition, of course, if we start with neoadjuvant, the response assessment allows us to give adjuvant medications such as TDM1 and capecitabine, and sometimes a PARP inhibitor if there's not a pathologic complete response. So we have a strong preference to do neoadjuvant treatment. And then we know from several studies, of course, that the MRI is, well, at least the most accurate method to assess response. So especially for surgical planning, we use MRI. So if we want to end up with breast conserving surgery, I would always have an MRI. So it's part of the standard workup for neoadjuvant treatment, and it's the standard follow-up procedure as well for response evaluation. In addition, there are some trials that use the MRI response during neoadjuvant treatment to de-escalate the systemic treatment or the surgical treatment. So we have a study for HER2 positive patients in which an MRI is done for response assessment, and if there's a radiologic complete response, you would shorten the neoadjuvant treatment. So that is quite a reliable tool and enables the patients to de-escalate treatment and improve quality of life. And similarly, we have a trial in which we omit sentinel node biopsy in case of a radiologic complete response for these patients. So in our practice, as in the Netherlands throughout, the MRI for neoadjuvant patients specifically is really embedded both in the workup and in the response assessment.
Muito bom. Doutora Ana Carolina.
Olá, bom dia. Em primeiro lugar, quero agradecer o convite. E é uma honra estar aqui com vocês, principalmente para discutir um assunto como esse, né? Que é o descalonamento. E eu quero comentar algumas coisas, mas acho que o principal aqui é a gente estar numa equipe multidisciplinar e é muito importante a gente estar buscando soluções e melhores perspectivas para essas pacientes que a gente sabe que biologia tumoral existe e funciona. Então, a gente está numa nova era da medicina, né? Então, quando a gente fala de descalonamento, e aí eu achei bem interessante as colocações do Dr. Lee, principalmente naquele slide que ele fala, né, de descalonamento para doença agressiva e para doença indolente, né? A gente hoje está falando de neoadjuvância, então a gente está falando de tumores que são mais agressivos, a gente está intensificando o tratamento sistêmico e a gente percebe que talvez a gente necessite de menos tratamento local, né? Ao contrário de tumores indolentes. E quando a gente fala de diminuir tratamento local, e aí eu digo isso, principalmente quando a gente está em congressos, né, em discussões, vamos omitir rádio, vamos omitir cirurgia, eu digo que costuma, em muitos momentos, até haver animosidades, né? Porque ninguém quer, todo mundo que quem opera acredita muito no seu tratamento, quem faz radioterapia também acredita muito no seu tratamento. A gente tem muita dificuldade, muitas vezes, em omitir e deixar de tratar essas pacientes, né? A gente tem que desapegar um pouquinho disso. E aí eu digo que a gente está numa nova era, né? A gente está falando agora de omissão de rádio, né? Mas omissão total, né? Evitar irradiar, inclusive, mama. A gente tem já o B51, né, que foi comentado também nas apresentações, não foi a apresentação principal, mas foi comentado, e aí eu digo que a implementação dele tem sido um pouquinho polêmico. Falo, tem muitos colegas radio-oncologistas ainda com receio de implementar o B51, por exemplo, né? Eu já tenho usado, e aí eu digo que quando a gente vai fazer qualquer tipo de descalonamento, né, assim como o Clécio comentou também, não dá para a gente descalonar tudo de uma vez, então vamos falar de descalonamento cirúrgico, descalonamento de radioterapia e evitar misturar, né? Descalonou axila, não dá para descalonar a irradiação de axila, mas eu acho que o principal é uma avaliação inicial bem feita. Então, o estadiamento inicial, o Badan fez alguns comentários em relação a isso também, e os apresentadores, né? Mas eu acho que sem um estadiamento inicial adequado, né? Então, essa paciente que a gente está selecionando para descalonar, ela está dentro do perfil desse estudo, né? Então, quando eu digo que eu me sinto seguro hoje em dia já em usar o B51, eu tenho que saber se essa paciente realmente é M1. E o que a gente tem visto na nossa prática, muitas vezes, a paciente ser deixada de ser encaminhada para a radioterapia, né, como uma resposta patológica completa, e na verdade ela não era um N1 inicial, que hoje em dia é o que a gente tem para poder descalonar a axila, por exemplo, né, e a avaliação pós neoadjuvância, né, eu acho que foi muito interessante a discussão disso, tanto para a omissão de rádio como para a omissão de cirurgia. Então, como avaliar adequadamente essa paciente que, em teoria, teria uma resposta patológica completa, para você evitar procedimento cirúrgico, por exemplo, né? E eu acho que a gente está chegando num momento em que, na verdade, a gente não tem que discutir se o que vai ser melhor, né? E aí, lato sensu, de forma geral, vai ser omissão de rádio ou omissão de cirurgia. Eu acho que a gente está num momento de personalização de tratamento, no qual a gente vai simplesmente avaliar uma paciente que fez um tratamento neoadjuvante e teve uma excelente resposta, e aí, para isso, a imagem, né, dados indiretos, eventualmente até ctDNA, enfim, a gente avaliando essa paciente com uma excelente resposta, e aí, a partir do perfil dela, se ela tem uma indicação cirúrgica, outra ou não, a gente vai omitir cirurgia ou radioterapia. Por exemplo, uma paciente que tem uma resposta excelente e ela iria para uma cirurgia conservadora, está satisfeita com a mama dela, não teria uma necessidade de uma intervenção cirúrgica, talvez para essa paciente a omissão da cirurgia e completar o tratamento com a radioterapia seja a melhor opção, né? Ao passo que aquela paciente que teve uma excelente resposta ao tratamento inicial, mas ela tem sim uma indicação cirúrgica, seja porque ela é uma paciente mutada, então ela vai para uma cirurgia redutora de risco de qualquer jeito, ou uma paciente que está insatisfeita com a estética, e ela vai para uma mastoplastia, vai para uma oncoplastia, omitir a radioterapia com tranquilidade. Então, eu acho que as discussões, agora a gente está ainda formando o corpo para isso, né? Então, a gente está formando opinião, a gente está enriquecendo nossa base de dados para isso, e eu acho que nos últimos anos deu uma acelerada, né? A gente esperou por muitos anos algumas respostas, e estudos que envolvem radioterapia, eles acabam demorando um pouquinho mais para recrutar, a gente acaba demorando um pouquinho mais para ter resultado, mas eu acho que cada vez mais a discussão individual dessas pacientes vai importar no final das contas e nos desfechos, não só nos desfechos clínicos, né, mas também nos desfechos de qualidade de vida e de desejo dessas pacientes em relação à escolha de tratamento. Acho que é isso, Renata.
Muito bem. Doutor Rodrigo, alguma consideração?
Oi.
Seu... O áudio está fechado, do Rodrigo.
Bom dia a todos. Agradecer também o convite do Dr. Henrique. Eu queria fazer uma pergunta para os palestrantes, porque muito tem sido estudado sobre o descolamento da cirurgia, da radioterapia e do tratamento sistêmico à químio. Em relação ao tratamento hormonal adjuvante, que alguns pacientes toleram mal, têm uma piora da qualidade de vida, né? Em pacientes, por exemplo, com HER2 positivo, receptor hormonal positivo, que obtiveram resposta patológica completa, vocês acham que haveria espaço para um estudo avaliando a redução de duração de tempo da hormonoterapia adjuvante?
Yeah. Can I answer that question maybe?
Por favor.
Because wait, I have to start my video as well. I think it's an extremely relevant question because well, for patients with HER2 positive disease who have a PCR, the question is what the contribution of intensified hormonal treatment would be. And this is a question that is currently being addressed within the EORTC breast cancer group concept. Our colleagues, Ayela Chai, who is a medical oncologist at Rambam Medical Center, we've been gathering data throughout Europe and possibly also outside Europe of all young patients treated with hormonal therapy following HER2 positive breast cancer, both neoadjuvant and adjuvant. And we hope to present some data at San Antonio, or a little bit later. That it takes quite a lot of time to gather this information, but we should have information on 1,000 of young women, and that could hopefully lead us to a proposal to de-escalate the hormonal therapy once we have reliable numbers of recurrence rates for this specific patient group. So nothing new yet, but at least from EORTC, we are working on answering this question.
Ok, obrigado.
Nós temos uma consideração aqui da plateia, então o doutor Cristóvão que falou, né? Com tantas opções de descalonamento, o que temos que definir agora é qual seria a melhor forma de descalonamento, já que todas não dá para ser, a gente não consegue fazer simultaneamente, né? E aí que o ideal é levar esses casos todos para tumor board e envolver a paciente também nessa decisão. Queria saber se alguém tem mais alguma pergunta para os nossos convidados, né? Aproveitar que temos aí, ó, Dr. Lee, Dr. Frederieke.
Renata, posso fazer mais uma pergunta?
Claro!
Eu gostaria de perguntar para os palestrantes, né? Pelo que eu estou entendendo, e eu gostaria que eles falassem mais sobre isso, porque é algo muito interessante para a gente. Então, quando a paciente tem uma resposta radiológica completa e ela vai ficar numa decisão se ela vai fazer uma cirurgia ou uma nova biópsia assistida a vácuo com o resgate do clipe. Isso seria semelhante do ponto de vista de recidiva local?
I don't know if our colleague from MD Anderson is still online. Because of course this is the most important question, whether or not you can replace the surgery with the biopsies. Our team was part of the slide that our colleague showed as well. We've done the micro trial in which we also did biopsies post-neoadjuvant in patients with a radiologic complete response, in fact. And then it turns out that the biopsies we did were not reliable enough, so we had a too high false negative rate. The point, of course, is that although maybe the local recurrence rate would be the same, since you will give radiation therapy in patients in whom you omit surgery, if it's a triple negative or HER2 positive patient and you miss the presence of residual tumor cells, then you also miss the opportunity to give post-neoadjuvant adjuvant treatment. So a patient with residual HER2-positive disease would need T-DM1, for example. And residual triple-negative cancer requires a PARP inhibitor or capecitabine. And I'm having some doubts, as I think it should be a really, really very reliable biopsy procedure if you are willing to risk missing out on the systemic option. So the local recurrence rate will be super low because it's already very low in patients with a PCR and a small tumor for HER2 positive, triple negative. It's only a couple of percent, and you're going to give radiation therapy, and it will for sure be equally low if you do biopsies as described in the MD Anderson trial, because it's 9 gauche biopsies and you take 16 of them, so it's as good as small surgery. But I'm a little bit worried about the systemic treatment. I don't know if this answers your question.
Yeah, I would like to add to that. Yes. I totally agree that the consequences are not in the local regional treatment. It's about the systemic therapy and the possibility of missing out on the chance for additional adjuvant treatment. And that's why in the Optimus trial, we have the primary endpoint as the disease-free survival, instead of, in contrast to the ipsilateral breast tumor recurrence in the MD Anderson trial, looking at the safety of omitting surgery for the breast after neoadjuvant systemic therapy. And I would like to add a little bit about the hormonal treatment and regarding hormone receptor positive and HER2 positive tumors. We do really have to, even if we achieve a PCR using HER2 targeted agents during neoadjuvant systemic therapy, we do have to consider the heterogeneity of the tumor, right? So the tumor, if hormone receptor positive tumors and HER2 positive tumors, they are really different. And some of the tumors that may be left in the body other than the breast, it has to be covered by hormonal therapy, in my opinion. So I think I'm sure there are the trials that Dr. Frederick mentioned will answer the questions, but I think we will have to approach it very carefully. However, for hormonal therapy, in my opinion, I think we do have to de-escalate or choose wisely on patients who would benefit from extended endocrine therapy, especially for the premenopausal women. We're offering 10 years of endocrine therapy for most of the patients now, but we do have some evidence that there are patients who do benefit from extended endocrine therapy and that do not. So we need to have better predictive prognostic models to predict the benefit of endocrine therapy. So in those areas, we can kind of de-escalate or shorten the length of endocrine therapy or the aggressiveness of the therapy itself.
Obrigada. Nós temos uma pergunta aqui, essa pergunta está em inglês, eu vou lê-la aqui para o Dr. Lee e para a doutora Frederieke. If we optimize systemic treatment and reduce chemo doses as TRAIN 3 proposes, could we still avoid radiation or surgery? I mean, only after 3, I don't know, and PCR, is there room?
The TRAIN 3.
3 cycles, yeah, and PCR. Is there room for more de-escalation, omission of radiation or surgery, breast and axilla?
Well, the TRAIN trials, so those are Dutch trials in which we de-escalate systemic treatment for HER2 positive disease. And since it's all in trial, the current thing we do is we do not also include the patient in our Descartes trial for omitting radiation therapy. So at this point, we do not combine, but for certain, once we have the long-term results, both from the TRAIN trials and from the Descartes trial, for example, then I don't see a reason not to combine those two de-escalations. But you have to be very careful if you do less on two fronts. So I think for now, those are separate strategies. And I just wanted to add that I completely agree with my colleague, Dr. Lee, that when you look at de-escalation of adjuvant hormonal therapy in HER2-positive patients, what we with the group with Dr. Shai are aiming for is to identify patients in whom, for example, ovarian function stimulation can be omitted or the duration can be shortened. But of course, those patients with triple-positive disease will always require some form of adjuvant hormonal therapy.
Renata, nós temos tempinho ainda, né?
A gente tem ainda, eu vou prolongar mais 5 minutinhos.
Não, tranquilo. Só aproveitar, pedir a opinião dos nossos palestrantes, doutor Lee, doutora Frederieke, que estão aqui conosco, sobre duas situações que assim, não ficou muito clara para mim durante as apresentações que eles fizeram, que é especificamente em relação, primeiro, a um subgrupo específico, que é o tumor lobular, o carcinoma lobular da mama, e o segundo é que a gente sabe que os tumores HER2 e triplo negativos, eles têm resposta morfológica distinta. Tumor triplo negativo geralmente é um tumor circunscrito que ele tende a ter uma regressão concêntrica até que eventualmente possa até ocorrer o desaparecimento completo. Isso não necessariamente acontece nos tumores HER2, que às vezes você tem uma resposta patológica e há sítios residuais distintos, como se fosse uma imagem salpicada desses tumores. Se esses estudos que eles estão conduzindo, que fizeram, foram avaliados subgrupos específicos nessas duas situações pontuais, ou seja, nós temos segurança, considerando essas duas populações, esses dois subgrupos, para também estar considerando essas duas possibilidades de omissão, seja da cirurgia, seja da radioterapia?
I think I could start with this question. Yes, you pointed out very well that there are different response patterns for different subtypes. For triple negatives and HER2 positives, without hormone receptors, they shrink in a concentric way. However, the scattered pattern for residual tumor is seen for hormone receptor positive tumors, especially the hormone receptor positive and HER2 negative, and also for triple positives also as well. So we do approach this very carefully if the tumor was hormone receptor positive. However, all of these patients who do have exceptional response to neoadjuvant systemic therapy are pretty aggressive tumors, and they have a high proliferation rate. So you can use the information from MRI and the enhancement in a combination with the subtyping and everything to assess the radiologic complete response before we get the biopsy of the tumor. In terms of lobular cancers, in our trial, it is an exclusion criteria. Lobular cancers are well known to have multi-centricity, multifocality, and at the same time, it is rarely seen with lobular cancers to have triple negative or HER2 positive disease anyways. So in our trials, lobular carcinoma is an exclusion criteria.
For the Descartes trial, it's so far not relevant, as in that all patients will have had surgery. So regardless of the post-neoadjuvant systemic
therapy MRI, they will have surgery. So there's no specific subgroup analysis to assess the correlation between MRI and pathologic response. There will not be many lobular cancers included because, well, the inclusion criterion is the presence of PCR, and of course that's less likely to occur in the lobular patients.
Obrigada. Eu acho que os nossos 5 minutinhos aí venceram. A gente ainda tem umas perguntas, a gente vai ver se consegue enviar depois essas respostas. Eu gostaria muito de agradecer a participação de todos, especialmente aí aos nossos palestrantes internacionais que permaneceram ao vivo para o esclarecimento das dúvidas. Viu? Foi um prazer enorme estar aqui com vocês. Parabéns aí a toda a comissão organizadora do Breastmit. E eu encerro então essa mesa, tá? Com os meus agradecimentos aí. Um abraço a todos.